Yes, good morning. Thank you very much for inviting me to this meeting, and I always enjoy working with surgeons, not only, in the operating room. And I was asked to talk about these stakeholders and what their roles, and I think Liane already mentioned some of the issues here. I would like to actually, I don't have any disclosure. The next. If we can imagine in a moment that the patient journey starts in the clinics where the surgeon sees the patient and then continues. And they're all put in rectangular very much, just to show that very much we are working in silos, as was mentioned before. So the pre-op and then the surgery and then the anesthesia and some communication and so on, and then home. And this is the patient's journey, but however, each of these sections are very much separate. And the idea is to avoid this concept of working alone. And I think that's where the ERAS comes from. So I'm going to talk about the team, because to me it's all essential in the creation of pathways. And I'm going to touch on who should be in the team. Leadership, I think, is very important. We need champions. And there are changes. As you probably know, physicians are the most resistant to change. And communication, and then sustainability. And I'm going to give some example. I think this is, to me, is an extremely interesting slide, because it shows very much the quality of the team, not only of the individual who participated, but also the people who are coming to the table. And as you can see, there are all qualities, and I think probably the most important to me is the fact that there's a trust. Trust amongst colleagues. You have professionals, and you respect the advice or the opinion of your colleagues, but because this colleague's opinion is based on principles like vision, creativity, communication, able to communicate to your team, knowledge. And I think most of the problem in applying the ERAS is very much lack of knowledge or assumption that other will do it for you. And of course, there is always a question of passion. You have to have a passion when you start that. And I said the charisma and champion. So it's all about that. Now, as you can see here, we started and we put around the table. Our experience starts really from the bottom. And I started some colon with one surgeon, and in 2006, and then we developed in 2008, and then became much more sort of established. And the idea is very much the key people who could be there could help, but becomes, as was pointed out before, very much a collegial concept. And then, of course, as shown here, the team meets together, I don't every week, when we think there is something to discuss about or to change. We change the esophagectomy pathway, for instance, 3 times, and so on. But the question is that you'd only meet those people, and that's where the champions can be. Definitely, we need a champion, surgeon's champion, who I believe still that has to be the leader. Despite the American Society of Anesthesiology, who talk about surgical home, that probably you heard about, I think that the surgeon has to have, in my view, and of course, collegially working with the group, the nutritionist, the pharmacist, and so on. And I think that the librarian, because I don't have time to go in the library or look for the latest evidence base, but the librarian is an extremely rich resource. We don't use it. We think about the librarian is still the one who puts the books on the shelves and so on. I think the librarians are much more up to date today. They know exactly how to do search, very professional, and is an excellent resource that costs nothing at all and is available. And I believe that the person who is important is, of course, this person here, which is, in our case, is the person who actually runs the coordinator. And I think that is a valuable resource that we should really use it. and may be justified because, of course, you need to justify to your chief of surgery or to our administration. And the question comes when we have a clinical expert, and that's where the clinical expert comes in. In this case is Lorenzo, who is a thoracic esophagectomy. We're doing the esophagectomy. And so we prepare everything. We came to him, and he said, the evidence tells us about this, and so on. And then we discuss about. And of course, we had surgeons who didn't agree to have the same pathway. But doesn't matter, you learn all the time. We had the nurses who actually were absolutely against, and they are against. But when we show the data, they actually 60, 70% of patients were going away at 3 days. Actually, the evidence was there, was clear. And don't forget to involve everyone. We only put a nutrition in pharmacy library. We have sometimes patients also coming to our meetings. But important, don't forget about the people who are maybe on the floor, the assistant, the one who, their clerk, because they are actually useful. And I tell you that the problem we had sometimes having the patient having the drink the same night, because nobody actually communicates with them, the patient had to be mobilized. So that's where the concept of a team comes up. Now, remember, you will have always the one who are really the innovators and, of course, the laggards. But the laggards are very few. But listen to them. I think we learn a lot from those who actually were against at the beginning. And communication, details are very important. We have to be extremely knowledgeable, and you have to repeat. And the Dutch have done this for many, many years, and they actually show that the moment you are relapsed, there is a risk of not being sustainable. So it's very important you maintain sustainability by reviewing your data and see exactly where you reach your goal that, 2 days, 3 days, we want to send home patients, yes, sure, but then make sure that this is continued. And of course, there's a momentum. Celebrate small victories. The fact that carb tricks now is every patient. We had a problem. Our patients were coming in the morning and said, preoperative nurses, clinics say, absolutely, you have to finish a drink, and so they come in the morning. No, well, did you drink? No, I didn't drink. Why? Oh, because the admissions office told me not to drink from midnight. Basically, we forgot to actually inform the admission office that this is the rule. So instead of doing only for the colorectal or for the esophagectomy, now everyone comes in the hospital. It has to come with the drink. And of course, give credit to the nurse. Remember, the nurses are the one who actually drive most of the time this in the pre-op clinic and in the post-op. That's extremely important. Address the concern. Go back and talk to them. Show the data. Barriers, I think probably the most barriers is lack of awareness and knowledge, because once you know everything is there, as implementation is the most difficult things to do. And this perception that from our side, from the anesthesiology side, says, oh, this is the surgeons or is the managers, and which is not the case. Completely change the whole concept. Well, I want to touch a little bit about this concept of collaboration anesthesia and surgery, which happens in the pre-op clinic. I believe there are issues that are common to all of us, and intraoperative and postoperative. But I want to say that just a few things about how some issues the anesthesia is aware that can help facilitate this recovery process. One is the concept of depth of anesthesia. And we always talk about the BIS, which is like an integrated ECG. We always thought about that this is actually ideal for detecting awareness. But we are moving very much for this concept of awareness, because the medication we have are extremely powerful. What we actually use in that more and more, in my view, is the fact of the sparing anesthetic tools. That means you give enough what you need, and therefore you wake up the patient faster. And then we know that the recovery room will be accelerated. So that's something to maintain the BIS between 40 and 60 and no lower than that. And there are issues related to also complications being seen. But that's where the trick comes, where you see in a different ways, not just to give an anesthetics, but you give an anesthetic for a reason. this is another interesting paper, Adequate Muscle Relaxation to Facilitate Surgical Approach. And they looked at what the depth of muscle relaxation, which is extremely useful. And probably all of you are working in laparoscopy, do you know how important is maximal relaxation? And this is an issue that has to be addressed by your group, by your colleagues. And their data are evidence, because the moment you go extremely deep, and we have a way to monitor, as anesthesiology, we monitor, we know very well that you can facilitate surgical approach. First of all, the pressure draws down. So you don't need to work at 15, 16, but you can go down even 10. There are some work in Belgium, where actually they go down, and these are laparoscopic bariatric or laparoscopic abdominal hysterectomy, where they actually go down, extremely down, even to 8. So less pain postoperatively and facilitating also the surgical approach. So this is, to me, is very important collaboration between anesthesia and surgery. Another one is maintenance of normothermia, and we know how difficult sometimes it is, but that's where it is important from the anesthesia point of view and from the surgical point of view to avoid great exposure in that to the ambient temperature, because we know that hypothermia has an impact on surgical infection and also ischemic changes postoperative, especially in our elderly patients. And ventilation oxygenation, we always tell anesthesiologists, be careful about barotrauma, using the PEEP, maximum oxygenation, because if you oxygenate maximum the lung, you have a less problem of diaphragmatic postoperative and also risk of pneumonia postoperative, atelectasis, and so on. So you see, they're all tweaking in a way. You adjust your ventilation and your oxygenation, especially in a deep laparoscopic or Trendelenburg position. And PNV prophylaxis, to me, is essential. I think most anesthesiologists realize that importance. And you see, we have tons of medications around that we can actually support this concept. And I attach that glucose is something that is becoming more and more aware in colorectal, especially in other areas, where we know that the risk of even 1 millimole increase, there is a risk of surgical site infection and pneumonia. So I think that we try to do our best intraoperative, but then we forgot postoperative. And I think that we should really be more attentive in the postoperative glucose. Now, stress attenuation, as I mentioned before, you see there is a huge amount. I love lidocaine. I think it's cheap, it's excellent, it costs nothing, and it's safe, because the amount we're giving, absolutely, there are no contraindications except if you have an heavy block. Otherwise, it should be used, in my view, and we used up to 48 hours. We never saw any toxicity, but of course, the pharmacy was still blocked by this lidocaine business that it cannot be used as a painkiller. And I think that's, we will come more later on. But I come in a little bit more to the question that your pain after abdominal surgery is a constellation of somatic, inflammatory, visceral, and that's a tricky one. But we have a huge amount of medication. And I'm really proposing more and more, we're starting a study, we actually showed them before in cholecystectomy and laparoscopic prostatectomy, where actually I think that the future should be non-opioid anesthesia and non-opioid analgesia. I think that's extremely important, and we can do it. I believe that we have an armamentarium that actually can be done. So that's where we want to continue also in the postoperative period, and that's where the domain of the surgeons and the team comes in. And thinking about beyond analgesia, don't just say pain relief, I think mobilization, think about nausea and vomiting, pain bowel function, respiratory depression, neural retention. So this is what the function is in acute pain service. It's not just analgesia, but also to avoid all the other side effects associated with the medication and so on. So home message, team, they have to work together. This is the future, and thank you very much.